Okay, let's get into it. Today we're doing a deep dive on something really fundamental for a healthy pregnancy, the Rh factor.
Yeah, absolutely crucial.
You might have seen it maybe on a blood donor card or something, but really understanding it, especially when you're expecting, it's vital.
It really is. And for this discussion, we're drawing on some great information from the American College of Obstetricians and Gynecologists, ACOG. Their FAQs are super helpful, very clear.
Right, top tier source.
Yeah.
So our mission today is pretty straightforward. Break down what the Rh factor is, why it matters in pregnancy, and critically, what can actually be done about it.
Think of it as your fast track to understanding this based on really solid medical guidance.
Exactly. So let's start with the basics. What exactly is the Rh factor?
It's actually pretty simple. It's a protein. It lives on the surface of your red blood cells.
Okay, a protein on blood cells.
Yeah. And it's part of what makes up your full blood type.
So if you have the protein, you're Rh positive, and if you don't, you're Rh negative.
You got it. Just like being type O positive or, say, A negative. It's that plus or minus sign.
Right. Part of the whole picture.
Exactly. And here's where pregnancy comes in. Your Rh status, positive or negative, it's inherited.
Ah, okay. Passed down from your parents? Genes?
Passed down through genes, yes, like eye color.
So it was in your DNA.
Precisely. Most people get that Rh factor gene from at least one parent, so they end up Rh positive.
And if you don't get it from either parent?
Then you're Rh negative.
Okay, makes sense. Inherited protein. So why is this such a big deal specifically during pregnancy?
Well, this is where we hit the concept of Rh incompatibility. It's potentially an issue when a woman is Rh negative.
Okay, she doesn't have the protein.
Right. But the fetus she's carrying is Rh positive.
Because the fetus inherited it from the father.
Exactly. Inherited the factor from the father.
When it's not like the mother's blood type itself is bad for the baby, right? It's more about how her body reacts.
That's the key point. Usually the mom's and baby's blood systems are separate. But sometimes a tiny amount of the baby's Rh positive blood can slip into the Rh negative mother's bloodstream.
It's a small amount.
Usually, yes. But her immune system sees that Rh protein on the baby's cells as foreign, unfamiliar.
Like an invader, a germ.
Sort of, yeah. It triggers an immune response. Her body thinks, I need to fight this off, and it starts making antibodies.
Antibodies designed to destroy those Rh positive cells.
Precisely. And here's the critical part, those antibodies. They're small enough to cross the placenta.
Oh, wow. So they can get into the baby's circulation.
Yes. And once they're there, they can start attacking the fetus's own red blood cells.
And that's where the serious problems can start.
Exactly. That attack can cause major health issues, even in the worst cases, be fatal for the fetus or newborn.
Okay, so how does that mixing even happen? You said it's usually just a little bit of blood.
Right. The ACOG info points out a few ways. It can sometimes just happen naturally during the pregnancy, or maybe more often during labor and delivery itself.
Right, delivery makes sense. Are there medical things that can trigger it too?
Oh, definitely. Procedures like amniocentesis, taking fluid from around the baby, or CBS, chorionic villus sampling. That's an earlier test on placental tissue.
Okay, those involve needles near the baby.
Yeah. And fetal blood sampling or actual fetal surgery, those are also possibilities.
What about like accidents or other issues?
Well, bleeding during pregnancy is one,
Yeah.
or if doctors try to manually turn a breech baby. Even significant trauma to the abdomen, like from a car accident or a bad fall during pregnancy. And importantly, ACOG also notes that antibodies can develop after a miscarriage or an ectopic pregnancy or even an induced abortion if that pregnancy was Rh positive.
That's a really key point. It's not just about a full-term birth. Any of those events could potentially sensitize the mother's immune system.
Exactly right. It's about the potential exposure.
Now, something that feels a bit backwards.
Yeah.
The ACOG info says this usually isn't a problem in the first pregnancy, even if there's incompatibility. Why is that?
Yeah, that's often surprising. The reason is it takes time for the mother's body to really ramp up production of those antibodies after the first exposure.
So not enough are made quickly enough to cause major harm the first time around.
Generally, yes. By the time her immune system has produced a really significant amount, the first baby is often already born.
So that first Rh positive baby kind of primes the pump, immunologically speaking.
That's a good way to put it. But here's the catch. If she doesn't get preventative treatment during that first pregnancy or after one of those events we mentioned, those antibodies she made, they stick around. Her immune system remembers.
Okay.
So in any future pregnancy with another Rh positive baby, her body is ready. It can churn out a lot of antibodies much, much faster.
Putting those later babies at much higher risk.
Exactly. The immune system is primed and ready to respond strongly.
So when those antibodies do cross over and start attacking the baby's red blood cells, what actually happens to the baby?
The main thing described is serious anemia, like a really low level of red blood cells.
Okay, anemia. And red blood cells carry oxygen.
Right. So severe anemia means the baby isn't getting enough oxygen. That's dangerous. It can also lead to jaundice, that yellowing of the skin and eyes you sometimes see in newborns. That's from the breakdown of all those destroyed red blood cells.
And in the worst cases.
As we said, it can be fatal. It's a condition called hemolytic disease of the fetus and newborn.
That sounds incredibly scary. But, and this is a big but, the ACOG information is really positive about prevention, isn't it?
Absolutely. That's the crucial message here. These problems are largely preventable today.
Thank goodness.
The whole goal is to stop the Rh-negative woman from making those antibodies to begin with.
How do they do that?
It comes down to two things: detection, finding out who's at risk, and medication.
Okay, so detection first. Step one is just knowing your Rh status.
Yep. Super simple. It's a standard blood test, part of your very first prenatal visit with your obgyn, usually.
Routine care. Got it. So what if the test comes back Rh negative?
Okay, if you're Rh negative and the baby's father could be Rh positive, or maybe you just don't know his blood type, then the next step is usually an antibody screen.
Another blood test.
Another blood test, yes. This one checks specifically if your body has already made any of those Rh antibodies and kind of how many.
And when do they typically do that screen?
Usually in the first trimester, and then they often repeat it around 28 weeks of pregnancy, sometimes more often, depending on the circumstances.
Okay, so you find out if you're negative. The antibody screen checks if you've already got antibodies.
Yeah.
If you haven't, that's where the medication comes in.
Bingo. That's the role of Rh immunoglobulin, or RIG. You might know it by a brand name like Rogam.
RIG. Okay. What is it exactly?
The ACOG FAQ explains it's basically an injection, a shot, that contains antibodies to the Rh factor. It kind of tricks your immune system. It essentially cleans up any Rh-positive fetal cells that might have entered your bloodstream before your own immune system notices them and starts making its own long-lasting antibodies.
Ah, so it prevents your body from becoming sensitized in the first place.
Exactly. It protects future pregnancies from potentially severe anemia caused by your antibodies.
Okay, so when is this RIG shot recommended?
Well, the ACOG guidelines list several situations. You'd likely get a dose after a miscarriage or abortion, especially if it happens at 12 weeks or later.
Right.
Also after things like an ectopic pregnancy or those procedures we mentioned, amnio, CVS, fetal blood sampling, fetal surgery.
Basically after any event where blood mixing is a concern.
Pretty much. Also, if you have bleeding after 20 weeks or abdominal trauma, or if they try to turn a breech baby manually.
Okay. And then there's the routine use during pregnancy, too.
Yes, that's standard practice now. A dose is typically given to Rh-negative women around 28 weeks of pregnancy.
Just preventatively.
Preventatively, yes. And then, after the baby is born, if the baby turns out to be Rh positive, the mother gets another dose within 72 hours.
To cover any blood mixing that might have happened during delivery.
Correct.
What about those earlier losses before 12 weeks?
The advice there is to talk to your obgyn. The risk of sensitization might be lower, but it's not zero, so they'll help you decide if RIG is needed.
Now, you mentioned the antibody screen checks, if you already have antibodies. What if you do? Does RIG still help?
No, and that's a really critical point. RIG is preventative. If that antibody screen comes back positive, meaning you've already developed your own Rh antibodies, giving you good, RIG won't get rid of them. It can't undo the sensitization.
Okay, so RIG is off the table at that point. What happens then? How is the pregnancy managed?
In that situation, the focus shifts to monitoring the baby very closely. Usually this means regular ultrasound exams to look for any signs that the baby is becoming anemic.
Checking the baby's health directly.
Yes. Looking for things like fluid buildup or changes in blood flow that can indicate anemia.
And if the ultrasounds do show the baby is getting severely anemic, what can be done then, according to ACOG?
If it's severe, sometimes delivering the baby early, before 37 weeks, is the best option.
Okay.
But if it's very severe, particularly earlier in the pregnancy, there's another option described: giving the baby a blood transfusion.
While still in the uterus.
Yes, directly into the umbilical cord. It's a highly specialized procedure, obviously.
Wow. That's incredible that they can do that.
It really is. It can be life-saving. If the anemia is only mild, delivery might just happen around the normal time, and the baby's body can usually catch up on making red blood cells after birth, maybe with some support.
Okay, so bringing it all together, the big picture here is really about knowing your status, getting the screening, and if you're Rh negative, getting that rig shot at the right times. That's the key to preventing these complications.
That's absolutely the main takeaway. Understanding your Rh status and following through with the recommended care, especially RIG, is vital for this pregnancy and any future ones.
And it sounds like it's been incredibly effective.
Oh, hugely. Because of routine testing and RIG, the severe problems from Rh incompatibility, they are so much rarer now than they used to be. It's genuinely one of the big success stories in prenatal care.
So this whole deep dive into the ACOG info
Yeah.
really underscores that, yeah, Rh incompatibility sounds complex, maybe a little scary,
It can, initially.
but these relatively simple tests and that preventative injection rig, they've made a massive difference. It's manageable for most people now.
Absolutely. Which just highlights again how important that regular prenatal care and open conversation with your obgyn is. Don't hesitate to ask questions about your Rh status.
Definitely. And that actually leads perfectly into our final thought for you to consider. Building on what we've discussed from ACOG, we've talked a lot about the Rh factor being genetic, passed down, and how knowing your status impacts planning for future pregnancies.
Right. The genetic link is key.
So thinking a bit broader now, beyond just the Rh factor, how am I understanding more about your own and maybe your partner's overall genetic background influence how you approach planning for your health or your family's health down the road?